afternoon, and welcome back to the 2020 HITLAB Innovators Summit. I am very excited to introduce our next panel, a fireside chat about the epidemic within the pandemic, to discuss innovative care delivery models for behavioral health through technology and measurement during COVID, moderated by Mainul Mondal. Mainul is co-founder and CEO of Ellipsis Health. Ellipsis Health, one of our summit sponsors, have pioneered the first artificial intelligence-powered, speech-based vital sign to quantify and manage depression and anxiety symptoms. By inventing scalable mental health tools, the company is democratizing emotional well-being for people across the world. Previously, Mainul helped launch the ClearStream initiative with the Freeman Spogoli Institute at Stanford University. Prior to Ellipsis Health, Mainul was a Rockefeller Fellow at the Public Health Institute. Mainul serves as a member of the World Economic Forum, working to improve the state of the world by engaging leaders of society to shape global, regional, and industry agendas. I will turn it over to you, Mainul, to introduce more of today's session and your speakers. Thank you so much for joining us.
Thank you, Justin, and thanks to HITLAB. It's fantastic to be here with our colleagues and friends and our partners. My name is Mainul Mondal. Hello. I'm the founder and CEO of Ellipsis Health. Ellipsis Health is a machine learning company that measures depression and anxiety symptoms through speech. For today's fireside chat, we've assembled a panel of leading experts, all of whom are changing the space of mental health, including Michelle Hoy of Mindsprings Health, Dr. Brent Lawlis of Alleviant Health Centers, Dr. Raj Agarwal recently at Jefferson Strategic Ventures, and Angela Schmiede of Menlo College. COVID has pushed our mental health system to the breaking point. We need a new path forward. I'm grateful to share the stage with our panelists to discuss how as an industry we can rise to this challenge. I'll introduce each of our speakers and we'll start a lively dialogue. Then I'll open it up to Q&A from our audience at the end. Welcome everyone. I would first like to introduce our first speaker, Michelle Hoy, EVP at Mindsprings Health, a community mental health center in Northwest Colorado. Michelle oversees all mental health and substance use disorder services at MSH. She joined MSH as a therapist and has had multiple roles in her tenure. MSH covers 10 counties in Colorado with urban, rural, and frontier communities. They also created MSH Matrixbased and won the Sherman Award for Innovation in Patient Engagement. MSH works with all payers with a focus on Medicaid and indigent care. They've used telehealth to deliver care for over 20 years as an early adopter, and I see it as useful for the long-term in psychiatry services. I'm also so impressed with their innovative response to COVID, figuring out a way to give their patients in need a cell phone, a data plan to ensure access to care. Imagine what that can do. Michelle, welcome. My first question to you, Mindsprings Health is a nationally celebrated for your care model. And we know that you recently trademarked your Matrixbased care. Can you please describe your model and also how it's changed since COVID?
Yeah, well, we are thrilled to be here. Thank you so much to Ellipsis Health and HITLAB for this wonderful summit. We at Mindsprings Health have trademarked Metrocovery, our new and award-winning pathway of care for individuals who are really experiencing difficult and severe mental health issues. What we were facing several years ago through insurance reform in the Affordable Care Act was many, many more people with Medicaid insurance in the state of Colorado starting to seek mental health services. I think it's akin to what we're facing right now with COVID, where more and more people are talking about and starting to think about seeking mental health treatment. What we knew at the time when we started on our journey to create Metrocovery is that we had high demands for services, and there's no new dollars and certainly not a lot or any new workforce coming our way. So we had to find an innovative and creative way to do more with what we had as our resources. And we knew that to do that, we needed to create access to care. We needed to engage patients in the care, not have them drop out. We needed to show that the work we were doing was providing good outcomes and high quality care. So with all of those basics in mind, what we did is we worked with through a lean Six Sigma process, and got a lot of our team members to sit with us and really help us think through, what does this new thing look like? And Metrocovery was really the result of that lean process. What it is we take several evidence-based practices and we stack them or bundle them. We take the concept of team-based care. It's a live concept that works every day in community mental health and in other practices. We have psychiatry, we have therapists, we have case managers, we have peer specialists, all of whom work with our clients. And when we have that team actually talk on a regular basis and agree on a plan of care, instead of just when a patient or a client is in crisis or just when something's getting difficult, we get much better results. So we doubled down on team care. We then stack in the concept of walk-ins as well as scheduled appointments. One of the difficulties our system was facing, that I think many behavioral health systems are facing, is that really the cadence and frequency and intensity of services was based on when the next scheduled appointment was available versus what the client needed. And so our clients who are in our Metrocovery clinics can schedule appointments, but they also have the opportunity to walk in. And that was a real live walk-in in the past. Now that we're here during COVID, it's often a virtual walk-in to a Zoom meeting, but we can also do this virtually. A walk-in where the patient or client can see anyone on their treatment team that they wish to, and they have the hope, promise, and guarantee that they can see somebody every week if needed. And they get to choose who they see on their treatment team, which is also really a very powerful concept. Then the third thing that we stack or bundle on top of those two concepts is the idea that illness comes in phases, including mental health. We started with depression, and we absolutely knew that when somebody comes to us and starts services, they are in their own behavioral health crisis of some sort. It's not on their best day that they decide to seek treatment. And that when somebody seeks treatment, we really need to mobilize our resources to that acute phase and meet their needs right then and there, not wait until it's available. And then last, but most certainly not least, the fourth concept is measurement-based care. It became very, very clear to me and to us as a leadership team that including a measurement tool at every session, every touch with the client was really important to provide an idea of where they're at with their treatment. Are they getting better or not? Because often they don't feel like they're getting better, but the score shows they're getting better. That we can be responsive to the worst symptoms they're having that day. And that this idea of measurement-based care had to be part of that work. So Metrocovery is based on those four concepts. And what we have found is that we can provide results that create patients moving through our system quicker, getting better quicker, we know that they're getting better. We are showing engagement. Only about 13% of our clients are dropping out of treatment when they're in this Metrocovery clinic. And we're getting amazing results. So to give you a sense of that, at week 6, well, let me start here. Most of our patients in our depression Metrocovery clinics, the average PHQ score was a 21, which is fairly severe depression. We call recovery a PHQ score of 10 or less. And at week 6, we have 63% of our patients or clients in recovery. And at week 12, 78% of our clients are in recovery. Those results are really as good as anyone is getting out there, including highly controlled studies. So we're getting amazing results. And on top of it, we are showing that the time it takes for somebody to see and engage in treatment from their evaluation, the average time is 4 days. If you can imagine that it's possible for somebody to see a psychiatrist, a prescriber, a therapist, whoever they choose, within 4 days of seeking treatment, that's it's like record breaking and earth shattering because it provides hope, it provides promise. They know that we're there to care for them and that we are going to do everything we can to help them get better. So this is the new model of care that we're very excited about, and potentially providing consultation to others to learn how to replicate this.
Well, thank you, Michelle. It's amazing how all these small steps come and bring about a big innovation, large innovation. So thank you. Thanks for that. Welcome, Brent. Our second panelist is Dr. Brent Lawlis, a psychiatrist and chief clinical officer at Alleviant Health Center, headquartered in Arkansas. He has pioneered the development of telehealth and remote monitoring services at Alleviant Health Centers, as well as meet the growing demand for remote care as the global pandemic developed. Alleviant Health Centers is a national network spanning 6 states and rapidly growing of mental health clinics specializing in integrative holistic psychiatry. The unique approach is aimed at finding and healing the root cause of the disorder with a combination of traditional therapies and new cutting-edge modalities. Brent, welcome again. Prior to COVID, nearly a third of the population was struggling with the mental health disorders. Now listen to this. Since March, the number has risen to 50%, meaning every other adult in the US is in active need of mental health help. How's Alleviant Health responding to this unprecedented wave of demand?
Yes, thanks, Mainul. It's a pleasure to be here at HITLAB, and thanks to Ellipsis Health for having us here. So at Alleviant Health Centers, we do believe in integrative, holistic behavioral health. So we believe in treating the entire person, mind, body, and spirit, and using alternative complementary medication, traditional therapy and medication, as well as innovative therapeutic modalities and escalated treatment. So through this pandemic, what we saw was a shift to telehealth. So we had already been building that infrastructure. About 70 to 80% of our patients were in person at the time. And within around a 2 to 4 week period, it was 70 to 80% were telehealth patients. We grew around 400% within that quarter, that first quarter after the pandemic. And so really we're just leveraging technology to take care of our patients there. Some of the escalated treatments that we utilize, one in particular, TMS, or transcranial magnetic stimulation, attempts to get to the root cause of the problem in the brain. So this is technology that uses a magnetic impulse to stimulate areas of the brain associated with depression and anxiety to cause new brain cell growth, or epigenesis, and neurogenesis, new neuronal connectivity. I give the example to my patients of Christmas lights, and in December, I think this is probably appropriate with Christmas coming up. And if one's out, then everything downstream is not working. But if we replace that one light, if we turn on this area in the brain, we can get all of these areas working in network again, and we decrease depressive symptoms. It leads to greater response and remittance. And so that is one way that we are really attempting to meet this demand, as Michelle mentioned too, is to heal people, to get them out of this system and not dependent on the system, help them regain, hope and restore purpose in their lives. So.
Well, thanks, Brent. I think that I'm super excited about how fast you're all growing and the impact you can actually have across the US here. So thanks for the comment. Our third panelist is Dr. Raj Agarwal, bariatric surgeon, PhD scientist, and most recently, ventures investor at Jefferson Health System in Philadelphia. His work focuses upon clinical, scientific, and technological expertise with respect to healthcare innovations, encompassing digital applications and health IT platforms, VR and AR solutions, medical devices, and interventional robotics. Raj, welcome.
Thank you.
Answering from the view as a surgeon, why is mental health so important for surgeons and care?
Yeah, thank you again, Mainul, and to Ellipsis and HITLAB. And it may seem odd to have a surgeon, a bariatric surgeon, on a panel such as this, because, I've wanted to be a doctor since I was 4 years old, and first time I was in an operating room, that's all I wanted to do. And it's all about acute care. And, when people asked me, even when I was in medical school, why do you want to be a surgeon? It was because I want to be able to fix stuff, right? And I enjoy doing that with my hands and intervention, all that kind of stuff. So it's a very much a kind of someone comes to you with a problem and you fix it. like completely cut it out, whatever, right? And I've been doing surgery now for over 20 years. And what I've realized is, it might seem a little dumb that it's taken me time to realize it, but that when we do surgery on patients, there's that physicality aspect, and we can improve, the physical aspects. But if we don't tend to the behavioral, to the mental, to the holistic aspects, they're not going to do as well. So let me put this in context. With bariatric surgery, which is my specialty now, when we look at our patients, 1 in 6 of them actually have a mental health clinic visit either before, during, or after their bariatric surgery, right? And that's actually a visit. That's not signs or symptoms. So it's probably closer to 40%, maybe 70% of our patients that actually have anxiety, depression, or more serious aspects of behavioral health. And when I look at my patients, we evaluate them in terms of, most of them have diabetes, so we check their blood sugar or their HbA1c. Most of them have sleep apnea, so we get a sleep study done, and that gives us their AQI index. We look at their blood pressure, so we look at their hypertension and many other things. And we measure all of those. And then what do we do for their behavioral health? All of my patients gets to be seen by a psychiatrist or a psychologist for an evaluation. And literally the focus there is very much, again, black or white. Is this patient cleared to undergo surgery? Yes or no? And if it's a yes, great, and everything else is good. And if it's no, well, maybe they need some further therapy and so forth. And then we do the surgery. And following the surgery, we diligently follow their blood sugar for their glucose, their blood pressure for their hypertension, their AQI index for their sleep apnea. And what do we do about their behavioral health? Nothing. At best, I might ask them in the clinic at 1 month or 3 months, how are you doing? How do you feel? That's literally the best we can do. And in this day and age, that's just not good enough. And what we also know, and this is pretty sad, is that there's a 3 times higher risk for our patients following bariatric surgery of being admitted to a mental health unit. And there's a 5 times higher risk of them actually attempting suicide, deliberate self-harm. And so we do all of this in terms of these patients, right? We get them all ready for this new life. And yet probably the most important thing, their holistic, their behavioral health, we kind of just see what happens, right? And let that happen. And that's just dumb, right? It's not good enough. It's just dumb. And so where my focus is now, and I've put this in the span of bariatric surgery, I was talking to a vascular surgeon yesterday. I mean, all of our patients, right, have some degree of behavioral health that can be optimized. And if they're going through this acute stage, whatever that intervention is, and we don't tend to their behavioral health, and more so, don't measure it. So we do that evaluation at the front end preoperatively. And okay, we can treat at that point. But what we need to do is, just like we have a blood pressure, we have a blood glucose, we need to have a test, a y-axis for what's happening for the behavioral health. And not that, yes, it's important that we can identify patients that aren't doing so well, but just look, my patients that are off their diabetic medications, off their blood pressure medications are so happy. Imagine if we can actually give them that scale and say, look, this is where you were in terms of your depression, and this is where you are right now. That is then going to seep out into their social unit as well, and really, really impact of how we think about this this intervention of bariatric surgery. So I'm excited to be on this panel. I'm a little late to the party in terms of just understanding the importance of behavioral health, but better late than never again.
Well, thank you, Raj. I think we're all late to the party to an extent, but the fact that, which is unacceptable for us as human beings on this earth, but the fact that we're talking about mental health in such a diverse way now, it's not just about mental health and from a mental health group, it's across what I'm seeing from my work. It's the surgeons, it's the mental health specialists, it's the primary care physicians, all across, and even school, obviously schools and students as well. So thank you. Thanks for the comment there, Raj. Our fourth panelist is Angela Schmiede, Vice President for Student Success at Menlo College. Angela is responsible for the well-being of our next generation. And we're excited to discuss how mental health can be discovered outside of the virtual or traditional healthcare. Menlo College is a small, private, nonprofit, 4-year residential college located in California. Menlo College's location in Silicon Valley has enabled the college to create a valuable market niche for its business and psychology students locally and globally. With its innovative curriculum and award-winning internship program, Menlo College cultivates in its students the skills, the integrity, and passion to make meaningful contributions. Angela, welcome.
Thank you, Mainul. It's a pleasure to be here.
Can you please share a bit about how you and the college have approached the pandemic with your students?
Absolutely. And Menlo College is really excited to be partnering with Ellipsis Health for this initiative. Even before the pandemic, mental health issues were increasing among the college student population. An American Psychological Association survey looked at college students and their mental health, and students reported 61% reported anxiety and 49% reported having depression symptoms. Looking around at colleges across the United States, we see that the counseling centers, they have wait lists because of increased needs for counseling. I've also been tracking the data. I've been really interested in what's been happening post-pandemic in terms of students' mental health needs. A recent study that was conducted by Texas A&M, they interviewed over 100 students, and students are experiencing exponentially increased stress levels, over a 70% increase in stress due to COVID. Menlo College, we're a small residential college. We have a very high touch approach to student success and support. So we had a number of initiatives and support systems already in place before that. When shelter in place happened in March, though, our students were on spring break, and we asked them not to return. So like many colleges, that was a change for students. It was very disruptive not to be able to return to the routine that they had before in their dorms. We immediately surveyed students regarding their needs when we went into shelter in place. The needs were many. A number of our students were experiencing housing insecurity. Food insecurity was also an issue. Technology challenges were pretty significant. It relied on students. When we moved to remote learning, students had to have adequate hardware. Anybody who had a Chromebook had some compatibility issues with some of the platforms that we used. Access to Wi-Fi was often spotty or unavailable. Students were often living in home situations where they had multiple people needing to use Wi-Fi, either siblings who were also doing remote learning or parents working from home and not having quiet spaces. Many of our students who work lost their jobs, or their parents lost their jobs, so they had additional financial stress put on them. Some of our students come from unsafe home environments, and so they were forced to be living in that environment. And then because of COVID, they also had concerns about their own health and the health of their families. 43% of our students are student athletes. They no longer had a sport to play. I think that was stressful in terms of their identity. We also had a graduating senior class who didn't get to celebrate their important achievement of finishing their 4-year degree with a traditional commencement. So layering on top of that, we had this summer we had issues with racial injustice and political instability, and that really created a perfect storm for increased anxiety for college-age students. What we did at Menlo College, we really mobilized into action in response to some of the needs that our students had. We provided emergency housing for those who would otherwise be homeless. We have a large international student population, and a number of them were also unable to travel home because of travel bans. We provided emergency relief aid through the CARES Act, and as well as some tuition discounts for this fall when we went fully remote. We have a laptop loaner program and provided access to hotspots. There was a lot of stress around academic performance, and so our faculty agreed to move to a credit, no credit grading system for the semester. More importantly, we were able to pivot all of our student support resources online, including academic advising, our career counseling, tutoring, and the mental health counseling. Unfortunately, due to state licensing, our counselors are only able to conduct counseling for those students who are physically in the state of California. So we also have been working one-on-one with other students to find the resources that they need if they are outside of California.
Wow. The number of sort of mechanics that go into making sure that we are getting to a point where we can feel better. I mean, the kind of steps you guys have all taken is astounding. Thanks for contribution there. Thanks, Angela. Mm-hmm. Michelle, going back to you, as a follow-up to your care model, can you please describe how you use matrix-based care combined with telemedicine?
Sure. As we have been really managing business and client care during the pandemic, we, like many other providers, really flipped from office to office telehealth, which we had been doing for a couple of decades and been very successful at, to doing this telehealth behavioral health work from our homes as employees and therapists and prescribers to many of our clients' homes. We were, of course, in our outpatient business, 100% virtual for a month or more, and we are really providing a hybrid of services now. We are continuing for anyone in a Metrixbased clinic to take measurement at every touch with the client, and we're doing that a couple of different ways. It could be as simple as me, the therapist, asking you, Mainul, the PHQ-9 questions and entering the answers right into our EMR. We sometimes have our clients coming into our office for several reasons, and they might still take the PHQ-9 or the GAD or something like that in office, and we feed that information to the therapist. We have what we affectionately call Zoom rooms now in our offices, places where our clients who need to come in and use technology can come in. We've also given out a lot of cell phones to clients who need access and engagement to stay in services and remain in a low level of care and not become in crisis. So we give them a cell phone with an unlimited data plan. And as long as they're connecting and engaging with us, they can use the phone and the data for anything they would like to. That is a service we're happy to provide. So we're continuing to provide this new model of care and trying to get very creative about how we keep people engaged. Again, no new resources in general coming. And so it's really about how we are really thoughtful and effective with the resources we have to continue to show that our clients can get better via telehealth, that we can reach them almost no matter where they're at, and that we are there for them. They still have some choice in the pathway of care. So those are some of the things we're doing to really manage how we're moving to telehealth during the pandemic.
Wow. Well, thank you. Thanks for the comment there, Michelle. Brent, sort of turning to you, building on Michelle, how is Alleviant innovating and adopting new technology to improve the standard of care?
Yes, well, one of our primary innovations is exactly what Michelle is saying, is just a team-based collaborative care model where we work with MPs, paramedics, and therapists in a team-based way to increase and improve access to care. So in traditional models where you're seeing a psychiatrist, you can often be scheduled out, 3 months or so, but we believe that when people are in crisis, they're experiencing mental health and behavioral health issues, they need to see somebody right then. So generally we can get somebody in to see a prescriber or a therapist within a week because of that model. So that's something that I think we're definitely doing that is innovative. We also believe in personalized and precision medicine. So we utilize psychogenomics and sort of genetic testing to determine which medications we can just eliminate that patients more than likely will have side effects to based on their genetic code. And so then when we're starting a medication, we know that there's a better chance, it's going to work. And then we combine that with escalated treatments and alternative and complementary medicine. A big part of what we do is community events where we talk about things like mind-body medicine, yoga for mental health. We talk about nutrition and diet and the brain-gut connection and things that we can do in a preventative way to improve our wellness and our health before we ever get to see a prescriber, a physician, or a psychiatrist. And we have those resources available as well on our website, and that's something that we just believe that if people knew better, that they do better. So awareness, insight, education is a big part of our model. as well, and engaging the patient in a personalized way. And lastly, we've been utilizing Ellipsis to really validate our methods and our models, sort of synergizing them together and seeing better validated outcomes. And lastly, with Ellipsis, I think with our TMS patients that are basically failing multiple medications, failing therapy, staying in a place of chronic depression, we're getting really good responses with this new technology. It's been around for about 10 years within the mental health realm. It was approved in 2008, and it's a non-medication alternative, procedural-based neuropsychiatric treatment that helps with depression. So these are patients that come in every day for about 8 weeks. And what they've really liked with Ellipsis is that we're continuing to monitor their anxiety and mood states even after they finish a TMS treatment course, because they've been so used to engaging with this support network of providers and clinicians. And so that's just given them peace of mind. And if we see a dip, we can call them, get them back into therapy, and help them out.
Thank you, Brent. I guess just a little bit of a follow-up there. Can you talk about sort of the success rate with treatment-resistant depression?
Right. So treatment-resistant depression, we're seeing really great success rates in the clinic. Response rates are over 50%, and remittance rates, and a lot of literature, you're looking at 20, 30% and higher, generally higher than meds and therapy combined. I would say, the overwhelming majority, over 80 to 90% of our patients, starting at PHQ-9s of, 25 or 24 and above, we get them to that sort of, threshold of 10 or below or 8 or below. So in most cases, we're decreasing medication burden, we're improving quality of life metrics, we're decreasing anxiety and mood states, and also we're getting full remittance. I mean, one of the patients that came to me was on 40 milligrams of Valium and 3 milligrams of Xanax for sort of generalized anxiety and panic disorder. And, working with meds and therapy and our other modalities as well, but with TMS and sort of a right-sided approach, treating the anxiety, we were able to get him off all the medications, and he's doing well. He's a new father, taking care of his new baby boy, and their marriage is strong. And so those are the reasons why we go into the field, into these fields to help people. And, it's just an honor to be a part of this panel and see what other people are doing innovatively to really take care of people.
Thanks, Brent. I think the feeling is mutual here. And I'll get a few more questions. I'll come back to you in a few seconds here. So I guess a question for Raj now, thinking about how we adopt technology. As a surgeon who's led innovation in a large healthcare system, what are the challenges around supporting mental health, implementing new technologies?
Yeah, we used to say in my team at Jefferson, everyone wants to be us. And then when they find out what we actually do, no one wants to be us, right? Because they realize that it's actually not all that sexy, fancy work and flying out to San Francisco every other week, but it's really, really hard work. So it's really hard work on two sides. One is having that engagement with the innovation, the technology. And I started my career in virtual reality and surgical robots. But whatever it is, whether it's Livongo for diabetes or it's Ellipsis in terms of behavioral health, right? It's a new thing. And the biggest challenge on that front end is to engage the providers and the current system in terms of the workflow. It's people, process, technology. And so I remember something even simple, you probably wouldn't even think about this as an innovation, but the surgical checklist that you probably know about, that Atul Gawande developed. We were one of the first sites in the world. There were 8 sites around the world. In my operating room in London, we were one of the first sites. And what did someone come? One of the study coordinators said, "Oh, Raj, you're about to start this cholecystectomy. Can you just do this?" And I just, what is this? Like, what do you want me to do? Oh, just answer the questions, right? And I just said flat out, no, I'm about to do a case. I'm focused on the patient. Now you're asking me to do something. You can't just turn up to my operating room and ask me to change my workflow because of something else. And maybe it's better, but it might actually end up being worse. And I think that's the crux of this, is that, if you bring in innovations and they're not brought into the workflow, into the front end, then you can actually lead to harm. and often do. And so that's that front end piece of just understanding the current state and then getting to that desired state. And then that's the back end piece of when you engage in this new approach, the innovation, the technology, whatever it is. It's really important that we are measuring the outcomes and doing that from a clinical perspective, from an operational perspective, and a financial perspective, right? And what we want is that we're improving the quality of clinical care, that we're enhancing the efficiency of care, and that that is either being done at the same cost or a lower cost, okay? Or sometimes at a higher cost. There's a trade-off there. We can have efficiency and quality at a higher cost. That's okay, right? And if we don't do that and we don't do it diligently, you mentioned in the intro, my background is as a PhD scientist, and that's what I bring to whenever we introduced innovations into our health system here at Jefferson and then transpose them to other sites. It's so important that you do that front end workflow piece, engage the people, the process, the technology, right? And take time to do that. And you do that in a stepwise manner. So you don't just say, okay, we're going to go across the system. You might want to start at one site and then look at feasibility, then take it to 3 sites, then take it to 10 sites. And then make sure that you are diligently measuring those outcomes, one, to prevent harm, but 2, to ensure that what we're doing is actually having an impact along those clinical, operational, and financial metrics.
Thank you, Raj. I think the item around workflow and being part of the workflow, technology only works, especially in healthcare, if it's part of the workflow. So thanks for sharing that insight. Thank you. I think, Angela, going back to you, just thinking about depression, anxiety in the adolescent space and then student space, college years, it's extremely important, and it's a personal passion of mine to be there for the kids who's actually make a difference for us in the future. Your college is known for innovation and supporting an entrepreneurial environment. For our audience, Menlo College is engaged in a project with Ellipsis Health to take the temperature of the emotional health of the community. Why do you think college-age students are a good fit for using voice-based mental health technology?
I think college-age students are a really interesting population and an important population to think about with regard to technologies like this. At Menlo College, most of our students are traditional age college students, and that means that most of them are digital natives. So they're very comfortable with technology. They've grown up knowing that for pretty much any problem they might encounter, there's an app for that. And so I think this will feel very comfortable to them. College students have also come to expect instant on-demand services. Here in the Bay Area, it could take weeks or months to get an appointment with a mental health professional. Even on our campus, it might take a few days for them to get an appointment with a mental health counselor. So the Ellipsis tool really allows students to access immediate information about their level of anxiety and depression and have access to resources that they can utilize right away until they're able to speak with a counselor. Here at Menlo College, students major in either business or psychology. So having the opportunity to adopt a fantastic tool like this to support mental health that uses machine learning technology also really taps into their intellectual interests as students. We're located in the heart of Silicon Valley, and our students are very interested in the entrepreneurial ecosystem here. So we've found that our students have interest both in the technology side of it as well as the health side.
Thank you, Angela, there. And this is actually one of my favorite questions for Angela. So following up on what you just said, your students were very, very involved in the development of our work together to address the emotional health of your community using our voice-based vital sign. And it was incredible to see them in action. What lessons or surprises did you find by getting their opinion on how to do this?
It was really amazing to watch them provide feedback directly to the developers of the tool. They had some unique insights and some things that I think surprised us and the developers. They were really focused on wanting assurance that their privacy would be protected, which is a little bit of a cognitive dissonance because they very freely share private information on social media all the time, but they really wanted to know who had access to data with the voice journals and how the data would be used. So it allowed us to really clarify that information for them. Students they recognized that users who would be using the app and the college student population would have a range of behavioral health needs. So they were very keen to think about students who just needed stress reduction to those who needed immediate crisis intervention needs. So they provided useful feedback about what range of resources would really resonate with students that we could add to the app. Everything from links to a mindfulness app or deep breathing videos to a suicide prevention hotline. And the students were particularly helpful in refining the language that would be used that would resonate with them, that would be on the user interface, and thinking about words that might be loaded or carry stigma with them, or might even be misinterpreted or not well known. A couple of our international students who looked at the tool, they didn't know what HIPAA was, so it allowed the developers to really clarify some of the language as well.
Well, thank you so much. It's been an incredible journey with you and with the students, and I've loved it. So thank you there. Raj, going back to you, I mean, we're aware of sort of adults going through stress and depression, anxiety, the kids, but I do want to focus on sort of our frontline workers or people who are actually providing care. Would love to hear perspective during this COVID period. The physician burnout, just provider burnout has been all-time high. How can health systems support our workers, and how important is identification of depression and anxiety?
Yeah, I think this has been a tough year for everyone, right? But I think back to, you know, as I said, I'm a bariatric surgeon. That's what I love to do. And we stopped doing surgery on March 16th. And we went back to doing surgery at the end of May. And I remember I had a backlog of patients that needed surgery. And I still remember it, going back to, you know, having an OR list of 3 cases that I'm doing. And I woke up that morning and, you know, pretty much hadn't been out of our bubble around our house. We live about 10, 12 miles outside of Philadelphia. And I got in my car and I drove to work and, you know, put on the N95, put another mask on, put a visor on, but, you know, had everything on. And there was a moment as I was about to walk into the operating room, I'd already checked my patient in. And I thought to myself, what am I doing? I'm putting my family at risk here. I'm like, you know, the patients had a COVID test 48 hours ago. What am I doing here? And immediately I thought, this is my job. This is what I'm trained to do, whether it's going into a room and treating someone with COVID, or, you know, I trained in inner city London, and, you know, we were exposed to HIV, hepatitis B and C, and you'd go into the emergency room and, you know, a trauma case, and you just do what was the right thing. And that to me is the right thing. And I remember thinking through that, and then, you know, did the cases and they all went fine, and was on my way home and thinking, wow, that was just me just going in to do elective surgery, something I've done, you know, thousands of. And just imagine what our ED workers, our ICU workers are doing, where they know they are going into patients with pneumonia, respiratory failure, who are COVID positive, right? That level of anxiety is just, you know, much increased. But again, it's the same thing. This is my job. This is what I'm trained to do. And this is what I love to do. And so this has been a really, really tough time of how do we think about our healthcare workers? And, you know, I'm from England, as I think most of you can tell. It's in the UK, every Thursday for a series of weeks, people used to get out on their balconies and clap for the NHS, right? Applause, okay? And literally there were videos, viral videos of Manchester, Leeds, London, people taking videos, and you could hear all this clapping going on. And I mean, it's giving me kind of goosebumps now that people really respect our health service, right? And yes, that's important. But what's even more important is that we actually talk about this, right? And not my intention to bring this up, but I don't know if any of you read that article by Meghan Markle in the New York Times when she said, you know, when she was asked, is she okay? And she said, I wish more people would ask if I'm okay. And I actually responded to that on LinkedIn, and I said, I wish more people would say, no, I'm not okay, right? And I think that's the aspect now. And I even wrote an article on LinkedIn early in March, where I said, when people ask you, you get on, get into a meeting, into a boardroom, how are you? You just go, I'm fine, And now you actually answer the question. You actually take a moment and you pause and you go, I think I'm okay, but, right? And I think that is a real silver lining. And, you asked about healthcare workers, but around how we think about ourselves, each other, and society as well, is let's actually listen to each other. And let's ask each other, are we okay? And let's actually answer honestly rather than just a passing comment, right? So I think this is critically important, and I hope we don't lose what I think we've gained as a society right now of really focusing on ourselves and each other. And I know you asked it from the lens of the workforce, but it's broader than workforce, it's everyone.
Absolutely. I think that it knows no boundaries, right? That's sort of the aspect of operating from a mental health model. So thanks there, Raj. Thanks for your comment there.
Can I jump in, Mainul?
Yes, of course.
I wanted to build on the concept of technology and workforce and workflows. And to speak to that, I do think that there is a huge role that we're still trying to figure out where technology fits in behavioral health. And Ellipsis is a great example. In our clinic that's treating adults with depression, we are using Ellipsis, and we're doing an IRB with you all to show what is working and get some outcomes. And we had to really think that through very clearly around workflows and workforce about when somebody leaves a voice journal and we get a PHQ-9 score, what then? What do we do with it? And to the point we were just talking about in terms of saving lives and helping people, especially if there's an elevated score that we're not expecting, what would we do? And that was a worry point for us and something we worked on. And we actually have an example from just last week where I think we would not have known previously. We don't have enough workforce. The individual leaving a voice journal through the Ellipsis app didn't have an appointment, chose not to walk into one of our clinics, but left a voice journal, and we got a notification because it was part of the workflow that this person had an elevated score, and we were worried. And we were then able to mobilize and go into action and outreach this person with our crisis team and really provide a service that I think was unexpected and helpful and really help stabilize that person versus, I think, in the old way, when we're not using technology to survey and we run out of time in the day to check on every patient, we just don't know how they're doing. Could have ended up in a crisis or a suicide attempt or psychiatric hospital over a long holiday weekend. So I think when we're talking about workforce, there is this question of how technology helps, and it's not just on me, the human, remembering to do some things, but that we need to start to think about how we use technology.
I can add to that, Menlo, too. I mean, I think that that's a very, very valid point. Is technology helping us, or is it causing us more stress and duress? And when we talk about healthcare professionals and burnout and suicidality, EHRs historically always come up because they're really revenue cycle management tools, which is good. We have to be profitable to keep our doors open and take care of patients, but they weren't really being designed with the clinician in mind. And so a big part of my job is to take care of the people who are taking care of the people who are suffering, right? Like all of our clinicians, and that's where we're starting. Is this technology intuitive? Is it seamless? What function is it serving? Just because we have the technology, it doesn't really matter if we're not implementing it into our own innovative systems and getting better quality outcomes. So I think that humanistic component of, what are we utilizing the tech for? Is it for, to decrease stress, to improve altruism or reciprocity or joy, like the things that matter in relationships? I think, that's really important when we decide how to engage the tech. The other part I would say about Ellipsis that we've seen with the audio journaling that Michelle spoke about is that people tend to open up in ways that they don't. And it's kind of getting to what Raj was saying, how are you doing? People respond, okay, it's just social etiquette. You have, your persona on your mask and you're responding in a way that's expected. And we build up these masks so that we can move and navigate through this world, even when we are depressed or highly anxious. And what we found is that with the audio journaling, people open up a lot easier with a machine and their cell phone than they even do with their own psychiatrist or their own therapist, just because of the defense mechanisms that are inherently in play in any interpersonal relationship. So that's another thing that we're really seeing with the tech as well.
Absolutely. I think Brent and Michelle, echoing the same. I think technology and humanness have to go hand in hand, right? The human connection, listening, are just so important. I think that's what we have to keep in mind. Ellipsis does as we evolve with our solution there. Brent, just a quick follow-up question for you. We're all used to seeing a psychiatrist or a therapist for years, as a standard psychiatric model has been rooted in symptom management. Do you think patients can actually heal from psychiatric disorders? And what other treatments do you use to support care?
Right. Absolutely. Yeah, I think that people can heal from these disorders. One medication, one symptom is sort of our traditional model, and we're managing symptoms where we're not getting to the root cause. We treat the root cause in the brain, but also the root cause can be in the thyroid. It can be in the gut. It can be in the adrenals. And so this concept of integrative medicine and just greater diagnostic assessment, where we're looking at toxicities and deficiencies, we're looking at metabolomics, we're looking at psychogenomics, we're looking at maybe, real-time brain imaging. And those are all innovative technology that if they're lumped together and stacked together, like Michelle is saying in her model, and synergized in an inductive way, and then can be validated on the other side that they're actually improving quality outcomes, which I think as healthcare professionals, we all know that they're going to, but it's hard to validate it with a scientific method that's more deductive in reasoning. And so I think, yes, absolutely. I mean, we've seen it. I mean, people leave our clinic and don't come back, and we're happy with that because, as you talked about earlier, the volume is increasing. I mean, people, anxiety and depression across the world, and businessmen have told me before, well, that's going to run you right out of business. And I said, if that's the case, then that'll be my legacy, and I'll find another industry to work in, right? But that's not going to happen. And to decrease the demand, and so it doesn't overwhelm our system, and we can still take care of patients, we've got to start healing people at the root cause.
Wow. Well, thank you, Brent, for that. We have about 5 minutes. I'm going to open it up to all of you, all four of you. If you think about 5 years from now, what is a new normal for patients, students, and population at large? We'd love to hear your sort of quick thoughts on that. Brent, Raj, do you want to go first? Oh, Michelle, go for it.
I can go, and I'm going to follow on from, the last 15 minutes of the discussion. And I think it's really around being able to be honest with ourselves and honest with each other. And, we talk about coming to work whole and being yourself when you come to work. And, Brent, you said not putting that mask on. And that's really hard to do, right? And it's much easier to say, well, my blood sugar's high today, so I'm not feeling so great, okay? Or my blood pressure's high, and, just take it down a notch or two, okay? And having that scale just for an individual, for me going, oh, so this is why I'm kind of a bit tetchy, whatever today. And so you can then treat it yourself, but you can also then talk to others. And then you can also talk to your medical professional. And then you talk about the medical workforce. You say, hey, look, I know I've got to go through these 20 charts tonight, but now's just not the right time for me because I'm just not in that right state. Let me go for a run or do something else, and then I'll try and do it tomorrow morning. So being able to objectify how we think about, our scale of mental health, mental wellness, I think is going to be so powerful for how we think about ourselves and how others think about us and we think about them, including our professionals. And so it's very simple, but just having that blood sugar where we can know how we're feeling today and why we're feeling like this, it is transformational. So simple thing, that's it.
Well,
Yeah,
simple things always win.
that simple thing, I think, is going to be one of the pieces that's really in our future, is really measuring behavioral health and behavioral health outcomes in a much more clear, consistent, standard way. I think really this idea of how we take what feel like the best that we can do. I really appreciated Raj's earlier comments that, the best that we can do is asking how you feeling. And when we run up against those brick walls, or we think this is the best we can do, I think we're all going to have to ask ourselves some really hard questions. How do we get over, around? How do we punch our way through that brick wall and stop thinking it's the best we can do and find a better way? There are better ways. And this innovation summit is part of thinking about how do we do it better? We've got to think about that. And part of that is, I think, to what Brent talked about, integrating more and more how we think about behavioral health and health working together and share information, resources, and data together to get to better outcomes. Those have got to be part of what we're doing together.
That's an awesome call to action there, Michelle. And as I said earlier, that's what we got to do: come together and truly make a change. So thank you for that comment. Angela, if I may ask you, sort of, what do you think was in mind with all this topic questions?
In higher education right now, we're talking a lot about issues of equality. And I think that technology has the ability to really help create a more equitable healthcare system, more equitable educational system. And this tool is really exciting for us to try that out and see what that looks like in a college setting. I think when you think about college students in particular and mental health issues, technology also allows you to talk more about mental health and to normalize it and make it part of everyday conversation so that there isn't that stigma that's attached to that, particularly when you have students coming from different cultural backgrounds where it might be taboo to even think about having a mental health issue. So we're really excited about the tool having that ability. I think Brent was talking about how patients were really getting into the voice journaling, the initial testing that we've done with the students. I think they really enjoy being able to talk, but knowing that this is a private conversation that they're having. So for people who might be reluctant to seek out mental health services, or there might be just a barrier in terms of insurance or whatever reason, I think it's a good first initial access point for the college student population.
Thank you so much, Angela. Brent, would love to hear thoughts.
Yeah, I mean, the new normal, I think, technology is going to be a big part of it, and it can equalize the playing field if we put the human elements into it and really think through these, in an innovative way, how we're designing our systems that we're all circumscribed within. And I think about the clinicians, because I think it has a really great capacity to decrease burnout. And if our clinicians, the frontline healthcare professionals, are well, you're going to see better quality outcomes with the patients that they treat. So I think that that's just a huge part of just that human element and how we decide to utilize technology moving forward.
Yeah, let me add to that, Brent. What I've always been taught is that I've been in technology for 20 plus years. At the end of the day, whether it's health, education, anything else that we do in society, it's about caring and it's about people. And technology is there to supplant that, right? And I think, unfortunately, when we come to summits like this, it's all about the technology. And so high tech is absolutely important, but we're all in the business of high touch, right? Whether it's health, education, that's why we do our jobs every day, right? And so how do we leverage that technology so that we can be better at high touch. That's essentially what we want to be.
Absolutely, Raj. Well, thank you. Thank you so much. Well, it's been an incredible honor to have you all with us. We have a virtual booth, and we would be thrilled to continue this discussion, conversation, dialogue with all of you. Please visit us over the next 3 days here. And thank you so much to HITLAB, our panelists today, and all of you for attending. Over to you, Justin.